Hello everyone, and thank you for standing by. Welcome to our webinar, Pregnancy, Birth, and Pelvic Floor Issues, sponsored by IsisParenting and presented by Dr. Roger Lefevre. My name is Nancy Holtzman, and I am the Vice President of Clinical Content and Online Learning here at IsisParenting. Tonight's webinar is being recorded, and you will receive a link to the recording by email tomorrow along with additional resources. So if you missed something or need to step away for any reason, that's okay. IsisParenting is pleased to offer tonight's webinar. ISIS is the nation's most trusted prenatal and early parenting destination. We partner with hospitals to provide innovative programs, classes, and services around pregnancy and childbirth, breastfeeding support and infant and toddler sleep, as well as early parenting and developmental programs. We offer classes and a highly edited selection of products for expecting and new families in our centers and online at IsisParenting.com. In addition to our 4 Boston area locations, we've recently opened ISIS Nests, located within Babies R Us locations. Come visit IsisParenting at Babies R Us at our 5 new centers in the Dallas-Fort Worth area and 4 locations in Atlanta, Georgia. Visit our website at IsisParenting.com to learn more. As I mentioned, I'm Nancy Holtzman, and I'll be moderating your questions in the chat room tonight. With me tonight from IsisParenting is Chris Just, our Executive Director of Prenatal Education and a Certified Nurse Midwife. Chris will be introducing our speaker and moderating this evening's discussion. Hello, Chris.
Thank you, Nancy, and thank you everyone at home for joining us this evening. During the presentation, all participants will be in a listen-only mode. However, you may submit questions to us at any time by typing them through the chat feature located to the left of your screen. We've incorporated many of the already submitted questions into the presentation, and we'll take additional questions as time permits. And now it is my pleasure to introduce Dr. Roger Lefevre. Dr. Lefevre is a board-certified OBGYN with advanced training in pelvic floor medicine and reconstructive surgery at Beth Israel Deaconess Medical Center in Boston. He helps women of all ages regain an active lifestyle following changes to the pelvic floor, improving issues such as pelvic organ descent into the vagina and urinary dysfunction, using treatments including exercise, medication, nerve stimulation, and surgery. Dr. Lefevre teaches medical students and residents as a Harvard Medical School instructor in obstetrics, gynecology, and reproductive biology. Additionally, Dr. Lefevre is able to offer his services to a wide range of patients as he speaks French, Spanish, and Haitian Creole. Welcome, Dr. Lefevre.
Thank you, Chris. It's my pleasure to be here. I am going to go over my objectives for this presentation. So at first, we're going to cover the relevant pelvic floor anatomy. Also, we're going to speak to how pregnancy and other risk factors can affect the pelvic floor. We're going to take a case format to cover the consequences of these injuries, and speak to some preventative intervention that we can incorporate to prevent these injuries. And I'll be glad to take questions at the end. So in terms of the anatomy, the pelvic floor, the bony pelvis encases the pelvis. So all the bone structures are gonna be protective for your pelvic floor. Connective tissue, think of it as more the tissue that surrounds each organ in the pelvis, such as your bladder, your vagina, and your rectum. The nerves would be thought as the circuitry, the wires that make all the organs work. And the musculature of the pelvic floor has different functions, such as lifting the organs and closing the organs, such as the sphincters of the anus and the urethra. So let's talk about the bones. In this picture, you can see the end of the spine represented by the sacrum and the coccyx. Also, the pubic symphysis is that bone in the front that we all feel. These are the most relevant structures in the pelvis. The ischial spine is also a bone that the head of the baby has to negotiate when it's coming down for vaginal delivery. And why it's important is because the pudendal nerve and the vasculature of the pelvis is around that area and can be compromised. So in terms of the muscle of the pelvic floor, if you look at this picture here, to orient you, you have the pubic symphysis. Again, that's the bone in the front that we all feel. And then you have a cross-section of the urethra, which is the tube that leads into the bladder. You also have a cross-section of the vagina and the rectum. So you can see around all these organs are many muscles, and the group that's circled here, the levator muscle, levator means lift. When you contract these muscles, they help support your pelvic organs. Now, when we think about the nerves, again, we think about the circuitry, the wires that make all the organs function. The most important one is the pudendal nerve, which sits right next to the ischial spine, and you can see that it gives many branches to the labia, to the sphincter around the anus, and to the perineal area. So that's the area that tends to tear or be cut with an episiotomy. So it's a very important nerve in pelvic floor function. So let's talk about the risk factors. And like I said, we're gonna take a case-based approach to it. And if there's any question throughout the case, feel free to submit it, and I'll stop to answer some of them. So our patient, Jane Doe, is a 33-year-old who comes to me complaining of urinary incontinence. So that's the involuntary leakage of urine during her exercises, such as kickboxing, running on a treadmill. She had her third vaginal delivery approximately 18 months ago, and since she's joined the gym with the goal of returning to her pre-pregnancy weight. Unfortunately, she cannot continue her exercises because of this urinary leakage. So on my initial visit with Jane, some of the questions that we would cover would be to address those risk factors. So for example, how was your last pregnancy? Jane in this situation would say something like, oh, my asthma was in control, I was coughing the whole time, I had a problem with constipation the whole pregnancy, and I gained about 38 pounds. I would inquire also about the delivery. In this case, her baby was 9 pounds 6 ounces, larger than the prior ones, and she pushed for 4 hours and finally had to have a forceps delivery, which involved an episiotomy, and she stated, oh, I had a few stitches. So let's talk about the consequences of all these risk factors that we just named. So urinary incontinence. Urinary incontinence is simply the involuntary loss of urine. There's two major types of incontinence. Stress incontinence, which would be not stress in your life, but physical stress onto your bladder, such as leaking when you do physical activity like coughing, sneezing, running. And the other major type of urinary incontinence is urge incontinence. So that's leaking of urine, but it's preceded by the sensation of urgency. You have the feeling you can't hold it, you can't make it to the bathroom in time, it's going to come out before you get there. As you can see, the prevalence of urinary incontinence increases with age. Approximately 30 to 60% of women who are pregnant will experience some degree of incontinence during their pregnancy. Approximately 35% postpartum, but we expect about 70% of them will have resolution within a 3-month period. So what is happening when we're considering stress incontinence? What happens exactly? So on the left side, we have the normal anatomy. So again, the pubic symphysis in the front there. We have the urethra, which is the tube that leads into your bladder, the vagina, and the rectum. They're all stacked one on top of each other. And you can see that there's good support under the urethra. Well, in a patient like Jane, who had the asthma with the chronic coughing, constipation where she had to strain a lot, and gain 38 pounds for the pregnancy, and push for 4 hours. So you can see that she has many risk factors that can lead to a tear, which would be represented on the right side of the picture, in the tissue that supports the urethra. And it's that tear, that lack of support, that keeps the urethra from compressing when you cough, sneeze, and laugh, leading to the urinary incontinence. Typically, in this situation, like I said, the symptoms should have resolved 70% of them in 3 months, up to 6 months. But she's 18 months after having the baby and still leaking, so absolutely she needs some help. So what are her resources? So Jane typically would speak to a family member, or mother, or sister, or girlfriend to see if their symptoms are normal. That's typically what I see. Is I've spoken to my mom. This happens to my mom. She can look in the media where there are articles in magazine, but those are sometimes written with an agenda, so we have to be careful about that. The internet has some good information. However, on certain blogs, there's some nightmare stories that tend to scare people as well. Jane can always speak to her primary care or PCP, and the recommendation usually at first is Kegel exercises. But urogynecologists such as myself are dedicated to help women with their female pelvic medicine, which means that we take a conservative approach. We use medication and pessary at first, and if you need surgery, we counsel you about it, and we try to stay minimally invasive. We take an individualized approach to your care. We also work with pelvic physical therapists, and take a multidisciplinary approach to your care. So let's talk about Kegels. There was some question on the chat about the Kegel exercises. Well, I'm going to cover Kegels several times during this presentation, and if there's more questions, we'll address them specifically. So how to do them? You want to focus your attention on the muscles at the entrance of the vagina, as if you didn't want to pass gas. The whole old way to teach this used to be when you're urinating, you try to stop urinating. However, we've moved away from that because it led to what we call dysfunctional voiders. So people were only doing Kegels when they were using the restroom to pee. So the better way to think about it, you want to contract the muscle at the vaginal entrance as if you didn't want to pass gas. You should feel a sensation of pulling inside the vagina. So you can work on two different aspects of the Kegel, the duration or the strength. So the duration would be you squeezing and holding for 3 seconds. So squeeze, 1, 2, 3, and release. And that you would repeat that 15 times. So that would be one set. So you do 3 sets of 15, and that's working on your duration. In terms of the strength, it's more of a quick flick. It's repetition. It's squeeze, release, squeeze, release, squeeze, release 15 times, and that's a set. And you would do 3 sets of those. So how does Kegel help? There's been a lot of debate about how helpful Kegels are. The literature is helpful in the sense that it was studied and it showed up to 60% reduction after 3 months. But the participants in the major study were compensated, so of course they were compliant. But in the real world, if you're anybody like me who joins a gym and then 2 months later you don't go to the gym anymore, then it's not going to work. That's where the pelvic physical therapist can be very helpful. It can improve your compliance by using newer techniques such as biofeedback. So what's biofeedback? Biofeedback is essentially a way for you to know you're doing it correctly. So the visual cues that you get are telling you, for example, that you're doing it correctly. So if you look at this picture here, you would get, there's 3 different size probes that can go either in the vagina or in the anus. And when you squeeze, you would see the corresponding response on the screen. Like you can see the orange part, that would be the right way to squeeze. So if you're not squeezing the right muscle, you would know, and that would really help reinforce your Kegels. The use of vaginal weight is feasible. However, it's my personal opinion that the biofeedback in coordination with the help of pelvic physical therapists has more compliance than you doing it alone at home, like everything else. So when Kegels don't work for stress incontinence, we use a device called a pessary. As you could see, it's a circular device. So this pessary has a knob which supports the tear that's under the urethra. We'll talk about different types of pessary for prolapse later on, but these continence pessary, the difference is they have a knob that supports under the urethra where, if you remember, that tear was. So pessaries are fitted, just like if you buy a parachute, you would try it. We try different pessaries, we try different sizes, and women really respond to it because they can use it, for example, during certain activities like running or jogging, and they don't have to wear it the rest of the day. Another conservative approach to the treatment of stress incontinence is an injection in the office. Just like women use collagen to bulk their lips, we can use an injection in the urethra at the neck of the bladder to kind of plump the bladder and narrow the exit of the bladder, hence providing some more continence. Sometimes the picture is not as clear, so we get complicated cases. In these cases, we perform what's called a urodynamics test. So think of it more as a conversation where we try to reproduce the symptoms that you're describing. The advantage of this is that we get a more accurate representation of what you're trying to describe to us, and it helps avoid unnecessary intervention. Our instruments are up to date and they're not too uncomfortable. When all else fails, we have a surgical solution, which is the suburethral sling. And as you can see, drawn in yellow here, the sling is an apparatus that's placed as an outpatient procedure, and it restores the support under the urethra. Usually, within 2 to 3 weeks, women are back to their regular activities, and the success rate is much higher than the conservative approaches. So now let's switch to urge incontinence. So that's the other major type of urinary incontinence. Pregnancy is not usually a risk factor for urge incontinence. So urge incontinence is, again, that urinary leakage that's preceded by the sensation of urgency. As you can see, your bladder starts contracting before you give it the okay, and that makes you feel like you're not going to make it to the bathroom. It can be a symptom by itself, or it can be part of a syndrome that's called the overactive bladder syndrome. So you can have urge incontinence or simple urgency. You can have urinary frequency. That means you go to the bathroom more than 8 times a day. Or nocturia is when you get up more than twice a night to go to the bathroom. So a large proportion is going to be due to your consumption of certain irritants like caffeine, artificial sweeteners such as Splenda, Sweet and Low, Equal, those kind of things, or any artificial sweeteners that you would find in diet drinks, Crystal Light, Diet Coke, and such. And the citrus juices also have acid citrate, which irritates your bladder. A smaller proportion is due to a deregulation in the nerve to the bladder. Now, our treatment for urge incontinence, again, is behavioral modification. We have a lot of handouts that kind of go over things to avoid. You can use your Kegel for biofeedback as well. This is more in the urge suppression technique, where when you squeeze, you send a signal to the nerve that calms down the bladder. So we call it the freeze and squeeze technique. So instead of running to the bathroom, you stop walking and you do your Kegels, and you should see the contraction kind of dissipate. When that doesn't work, we have some medication to help with the urge incontinence. If you turn on the TV, I'm sure you've seen those commercials about gotta go, gotta go. So on the market now, there's about 6 to 7 different medications that you can try. The side effects, it's our job to kind of guide you to the side effect. The main ones would be dry mouth and constipation. And contraindication, we don't want to give it to somebody with glaucoma, somebody with already constipation issues, or somebody with arrhythmias. But these medications are very effective once we find the right one and the right dosage for you. If medication doesn't work, we have other therapies that are more about regulating the nerve to the bladder. Remember, the nerve is a big part of your pelvic floor. It controls the organs, and if we modulate the nerve, we can control the contraction of the bladder and help you with your urge incontinence. So there's different ways to do this with the sacral nerve or inner stim, or the posterior tibial nerve, which is more like a acupuncture needle that goes in around your ankle, and you come to the office once a week for 12 weeks to have stimulating session that can help regulate your nerve. When all else fails, there's always Botox, which kind of temporarily paralyzes, or for lack of a better word, or reduces the ability of the bladder to contract. So let's get back to Jane and talk about other symptoms that can happen with pelvic floor injuries. So Jane come back 5 years later, and with that, like everyone else, she doesn't volunteer it, but on the questionnaire that we distribute to our patient, we realize that she's been experiencing some fecal incontinence. So when we talked to Jane, it started out as accidental gas. It worsens. Now she has little smearing and has to wear a pad when she goes to the gym. So fecal incontinence can present in different ways. Like I said, like it can be gas, it could be small pellet to a whole urgent full bowel movement. The risk factors for Jane for fecal incontinence would be her constipation, where she had to strain for a long time. The forceps delivery, remember she said she had a few stitches, but sometimes the episiotomy can cause some damage to your continence mechanism, and you end up having problems with your stools. So the sphincter, which is the circular muscle that keeps the anus closed, can be damaged. You can damage the connective tissue that surrounds the vagina and the rectum. And chronic constipation can in itself cause hemorrhoid, which often leads to smearing and not a full incontinence. I want to go over the tears that are very common during pregnancy, because if you remember, Jane said something, oh, I had a few stitches. But these are important to know because you want to know how bad of a tear you had, because that can help you gauge how badly or how likely you are to develop fecal incontinence. So a first-degree tear would be just the vaginal mucosa, the skin of the vagina. A second-degree tear would involve the muscle right around the entrance here. So this would be the one circle superficial transverse muscle and the bulbocavernosus muscle, so the muscle at the entrance. When it goes further down and involves the anal sphincter, it's a third degree. And if the tear extends all the way into your rectum, that's a fourth degree. We'll get back to why that's important. So fecal incontinence, we call it the silent affliction because it's very hard for women or any patient to talk to their doctors about it. Luckily, we distribute questionnaires, and oftentimes we pick it up that way. And oftentimes people are afraid of the evaluation process, what's involved in the evaluation. And it's not as bad as you think. It's a bowel diary, so you just keep a diary and you let us know how often this happens to you. On a physical exam, we're going to assess if there is any damage to your sphincter. And you may need some more extensive testing, such as an ultrasound, to kind of evaluate the sphincter and make sure there's no tears. Again, forceps delivery and fourth-degree laceration are notorious culprits for this. What are the conservative options when we talk about fecal incontinence? You're beginning to sense a theme here because Kegels are going to be part of everything pretty much. But dietary changes are going to be big. Anti-diarrhea medication can help. Fiber. Everybody thinks of fiber for constipation, but fiber can also bulk your stool, so give your stool a little more volume so you have less incontinence. Again, physical therapy can help you strengthen some muscle that can compensate and help you tighten the exit of the anus. When that doesn't work, we have several surgical options. the first surgery here is called a sphincteroplasty, and as you can see on the picture on the right, there's a tear in the circular muscle at the exit of the anus. So that's what gets cut during your episiotomy. That's what gets torn during your laceration. And our goal is to join the ends together and make them overlap and suture them together. It works well initially, but the literature shows that it loses some efficacy over time. If a less invasive option is what's called a Celesta injection, and again, in the same manner that we can bulk the exit of the bladder, we can also bulk around the sphincter there. This works really well for people with smearing or minimal incontinence. A colostomy would be the end of when nothing else worked. We would go to a colostomy, but that's not a very common thing for fecal incontinence. In 2012, the fecal nerve modulation, which we talked about when we were mentioning urge incontinence, has been approved for fecal incontinence because it can control the same nerve that control the muscles at the exit of the anus and help you regain some continence. This procedure is minimally invasive. It's outpatient, and it takes there's two steps to it. One is the placement of the wire in the lower back next to the nerve, and it's done under local anesthesia, just with lidocaine, the same you would get at your dentist. And we do it on X-ray so we know where the nerve is. You go home with a little battery that's about the size of a beeper, and you keep a bowel diary for 2 weeks. And what we're looking for is more than 50% reduction in your accidents. And if that happens within the 2 weeks, then you can return to the operating room and we put the battery under your skin. So in the same way that a cardiac patient will have a pacemaker for their heart, you can have a pacemaker to control your fecal incontinence. The batteries last about 7 to 10 years, and depending on the program or the intensity of the electricity that's required to control your incontinence, we would change this battery between every 7 and 10 years. So other things that can happen to Jane. So 20 years later, we see Jane, and now she's gone through menopause. When we examine Jane, her estrogen level, of course, have been lowered after menopause, and she develops what we call urogenital atrophy, and that's what's represented on this picture here. On the left side, you can see a premenopausal vaginal tissue that's really thick, well estrogenized, and wavy and undulated. And once menopause, a couple of years into menopause, it gets very thin, flat, and kind of dry. And that tissue is a lot weaker and can lead to what we call pelvic organ prolapse. So Jane would present with symptoms of vaginal pressure that gradually get worse. She can feel a bulge when she's standing. Sometimes they would say, I feel this extra skin in my vagina. I feel like the stool is stuck every time I have to have a bowel movement. This can lead to problems in their sexual life, such as embarrassment, and occasionally some patient thinks they have cancer. But pelvic organ prolapse can be very, very disturbing to our patients. So what are Jane's risk factors? Well, now she's postmenopausal, but some of the things that happened to her during her pregnancy are contributing now or manifesting itself now. So the asthma with the chronic coughing could have caused a tear in the tissue that support her organs, and now that their tissues are weaker, the tear lets the organ through. Same thing with constipation, same thing with the weight gain. The forceps delivery could have done some damage that we tried to repair, and remember, a few stitches, which when you're premenopausal, you have good muscle tone to compensate for it. But once menopausal set in, some of these symptoms manifest themselves. So let's talk about prolapse. I'm going to spend a little time here on this to try to describe what exactly happens. So we're going to think of the pelvic floor in the three-level concept. If you remember the prior pictures, the three organs are really stacked one on top of each other: the bladder, the vagina, and the rectum. So here on this picture, the patient is on their back. The black line is the tissue surrounding the vagina. Above the vagina is the bladder, and below the vagina is the rectum. So when I explain this to my patient, I use the analogy of a 3-story building. We're on the 2nd floor, we're on the vagina. On the 3rd floor would be the bladder. If you have a problem in your ceiling between the vagina and the bladder, then your bladder is going to drop inside the vagina, and that's called a cystocele. If you have a problem in the floor of the 2nd floor, so the floor between the vagina and the rectum, then your rectum can bulge upwards, and that's called a rectocele. The ligaments of the uterus can also be compromised, which leads to uterine prolapse. So here is a representation of what the uterus would look like if it's coming down. You can see the cervix is all the way at the entrance of the vagina. So sometimes patients say, I feel something hard at the entrance. In this picture here, on the left side, you can see that it's the bladder that's coming down. It's more of a mushy bulge that they feel. On the right side of the picture, it's the rectum that's bulging, and this is where they report that I feel the stool is stuck at the entrance of my vagina, and they have to do a maneuver called splinting, where they have to reduce or manually push the rectum back inside to have a bowel movement. Again, asthma, constipation, weight gain, large infant, all of these risk factors occurred way in pregnancy but manifest themselves often later on in life. So pelvic pressure, sensation of bulge, low back pain, all of these can be symptoms of vaginal prolapse. It can affect your sex life. So immediately after vaginal delivery, although the laceration have been repaired and they scar very well, it can still cause some discomfort. So it's important for you to really ask your obstetrician what type of laceration you sustained during your surgery, and not accept this answer, oh, you're just getting a few stitches. After delivery, during the breastfeeding period, your body has low level of estrogen, and low level of estrogen can cause irritation in the vaginal tissue. This is completely reversible once you're done breastfeeding, but in some patients, the temporary use of vaginal estrogen cream can be very, very helpful. After a vaginal delivery, you can have some laxity in the vagina, so loss of friction, lack of sensation, and that can really affect your sex life. This is where Kegel exercises are helpful. Once you're healed from your laceration, you should consider resuming your Kegel exercise, which will help give your pelvic muscle some tone, and you can regain some of the firmness or tone in the vagina that helps you during sex. So some of the myths and misconceptions that I hear on a daily basis. This is just part of being a woman. Oh, my mom had this, so it's okay for me too. It is annoying, but I thought I had to wait until it was really, really bad. I want more children, so I was told to wait and not seek help. I hear surgeries cause many problems. I've seen all these commercials on TV. So these are kind of the myths or the quotes that I hear from patients every day. But I'm here to tell you that prolapse is not an old woman's disease. It can occur earlier as well if you have significant tears. So how will you be evaluated for your prolapse when you come to see somebody like me or your gynecologist or any of my colleagues? It's very similar to your annual exam when you get a pap smear. Not the most fun thing to do, but we use a speculum. The difference is we ask you to push and strain and bear down like you were trying to have a bowel movement, because we're going to take some measurements so we can grade your prolapse. So we have tools like you see on the bottom that's called a pop stick, a pelvic organ prolapse stick, which will allow us to measure all these different points that are represented here and help us grade how bad is your prolapse. So 0 degree would mean that your organs are well supported. whereas a fourth degree means that the organs are coming outside. So just as we've been doing the whole presentation, we always start with conservative treatment. Again, Kegels here. Kegels here work differently. If you remember those levator muscles, or the muscle that keep, when they contract, they lift the pelvic organs. So that's how Kegels are going to help in this situation. Local estrogen. If you have severe vaginal atrophy where the tissue is very thin, you can use local estrogen, vaginal estrogen twice a week temporarily to regain some of that strength. Pessaries. We had talked earlier about incontinence pessaries, but you can see on the pictures there's a wide variety of different pessaries that we can help, that we can fit you for to help support your organs that are coming down. So let's talk about the pessaries. Like I said, there's different shapes, different form. The fitting process is not something to be afraid of. Think of it just you're going to try different sizes until you find the one that fits you. So it looks like a diaphragm, if some of you are familiar with that. That used to be used for contraception. And it's folded and fitted to hold the uterus. If you can see on the right side, you can see the pessary, for example, in this case, is addressing the uterus. But there are pessary to address the bladder. There are pessary to address the rectum as well. So it's a trial and error thing, because no one can reproduce your daily life, not in our office. But we try. We have you walk around. We have you squat and push and see if we want to give you the size that's going to fit and not fall out. And it does happen that you go home and it falls out. So it's not the end of the world. You come back and we give you the next size up. When these conservative approaches don't work, we offer you surgical management. And nowadays, we have a variety of minimally invasive approaches to choose from. The goal of surgery in this case, we're not doing cancer surgery to save your life. We're doing surgery to improve your quality of life. So our surgery should address the most bothersome defects or the most bothersome symptoms to you. Our goal is to preserve your vaginal depth, that you have a functional vagina, and that the repair is going to last you for a long, long time. We can do things through the vagina, which is the natural orifice. We can use laparoscopic or robotic, which have small incision, which helps you heal much faster and return to your activity within a matter of 2-3 weeks. But sometimes an abdominal or traditional approach is necessary. So this is the portion of the presentation that a lot of you will be interested in. So it's the preventative intervention that we can do to help prevent all of this. So weight control. Weight is a big factor. So if you live your life at a certain weight and all of a sudden you gain 40 pounds, it's a big strain on your pelvic support, the bones, the muscles, and even the nerves. So regular exercise, and this is not just to lose weight, but to strengthen the pelvic floor are important. Correct lifting techniques are going to help. Things that are going to put direct pressure on your pelvis you have to avoid, such as constipation. And as we all know, cigarette smoking is bad, but here cigarette smoking can affect the quality of your tissue as well. So here I want to pause for a second and talk about Kegel exercises. So there are different articles that we've been that have been brought to my attention by many of my patients recently about how effective are Kegels and what is the literature show, and even some articles that speak that Kegels are not effective, but squatting is effective. And what I want to say to that is, in terms of the squatting, there's really not a lot of credible literature, but there is a valid point to be made here for squatting. Kegels, as we talked about, helps with urinary incontinence, with stress incontinence, urge incontinence, and pelvic organ prolapse. Whereas squatting has a role in stabilizing the alignment of your pelvis. So you would use squatting for a different reason than you would use your Kegels. So squatting would be somebody who has pelvic pain and you're trying to restore their alignment. And this is where the pelvic physical therapist would be very helpful. And we're all referring to squatting, but there's other core exercises that work your core muscles that can help you with posture and take off some of the pressure on the muscles that are causing you pain. So it's not that I'm saying that Kegels are better than squatting. I think Kegels there's literature behind Kegels, but Kegels have different indication than squatting. Constipation. So fiber supplementation is important in treating constipation because you want to have a soft but bulky stool that will pass with ease without you straining. So you can take stool softeners, laxatives, and your goal should be to, again, not strain and have a bowel movement about every 2 to 3 days at the most. There's positioning on the toilet, as you can see. You want a 90-degree angle, and you don't want your pelvis tilted downwards while you're having a bowel movement. So things to think about during your labor. So during the 9 months of your pregnancy, you have many, many chances to discuss this with your obstetrician. So you want to ask you want to find out what type of practice your physician has, whether they do a midline episiotomy or what we call a mediolateral or sideways episiotomy, because the midline episiotomy can extend easily into your rectum. When they have to help you get the baby out, do they use a vacuum or do they use a forceps? Forceps are associated with larger tears. And when they mention, oh, just a few stitches, I'm just going to put a few stitches, you want to really ask, what type of laceration do I have? Is it a 3rd degree, which means it involves my sphincter, or is it a 4th degree that extends into the rectum? When they repair the laceration, you want to say, did you have to put together my sphincter? Did you have to repair my rectum? You want to know all of this so that you can discuss this further in the future and prevent some of the issues that we discussed earlier. During your postpartum period, it's important to have a good healing process. So ice pack, maintaining good hygiene to avoid the suture breakdown. You don't want to use ointments that can harbor bacteria. Again, we mentioned during the breastfeeding period, you can have a low estrogen state. So if you have symptoms of vaginal dryness, discomfort, you may need to talk to your physician about temporary vaginal estrogen. In terms of Kegel, if you haven't figured out, I'm a big proponent of Kegel, so I think you should resume them as soon as possible if you don't have any laceration, or wait until you're healed and start your Kegels also. During your postpartum period, especially if you lost a lot of blood during the vaginal delivery, you're going to be prescribed some iron supplement, which in itself can cause some constipation. Some narcotics, some pain medication that can cause constipation. So you really have to be careful during that time because things are healing and you don't want to make them worse. Now, people ask me all the time, what is normal? So having a little bit of urinary incontinence or even fecal incontinence at just 6 weeks visit is not uncommon, but it should be improving as time goes by. And the markers are by 3 months you should notice a good improvement. If they're still present at 6 months, they're not likely to improve much, and you need to discuss what the next steps are with your OBGYN or your PCP. And consider coming to a pelvic physical therapist or your gynecologist that can coordinate this care for you. Now, for people who had a C-section, there was a question submitted about the fact that this person had 2 C-sections but still had some symptoms. And that's common because it's not just the delivery process that can cause the injury. It's, again, you have a gravid uterus, a pregnant uterus that's weighing for the 3rd trimester on the pelvic floor. Things like constipation, asthma, heavy lifting, weight gain. And some people have a C-section after they try to have a labor. So the labor in itself can cause some damage. And even if they ended up with a C-section, they can still have had some of the damage. So my thoughts on C-section are that a vaginal delivery has been done for years and years and years. So to choose to have a C-section just to prevent some pelvic floor damage, I don't think it's a good idea. It's a major surgery. You're going to be exposed to having bleeding issues or even infection in the incision. It's a longer stay in the hospital. I understand there's scheduling practicality here, but if you take these recommendations and talk to your OBGYN and kind of prepare yourself, you should do well with a vaginal delivery. So these myths, these are my answer to the myths that we talked about earlier. Is this just part of being a woman? Well, my answer to that is it's not. Incontinence and prolapse are not an old woman's condition. And if this happened to your mom, just tell your mom, I can help her. There's help out there. If it's annoying to you or affecting your sex life, you don't have to live like this. Everyone is mentioning these ads on TV that talk about the vaginal mesh and such. There are non-surgical options available, and people also mention that, I have to wait until I'm done having children. You don't have to wait. There's things you can do before you're done having children that can improve your quality of life. The hardest part as a male that I encounter is that women are often shy to talk to their doctor about this. But remember, you went through labor. There was a lot of people in the room, and you were very exposed, and you went through that. So you should feel that it's easier to talk to your doctor. I want to thank you for your attention tonight. I'm happy to take questions at this point. And there's some questions that have been submitted that we're going to read out loud and then we're going to address. Thank you.
Thank you very much, Dr. Lefevre. We did have a couple of questions that came up during your presentation and some that were submitted prior to. One question, I think you were very clear that Kegels are absolutely recommended and proven to work. They've been studied. We did have a question, however, about the type of Kegel. One person asked if the quick pulse is as effective as an elevator Kegel. She had heard that the quicker one is not effective. What would you say to that?
So again, my answer to that would be it all depends on how you're going to use the Kegel. So for example, what you're referring to is the difference between what we call Kegels for duration or Kegels for strength. So if your goal is to help you with stress incontinence, you want to do the one with the strength, because that's going to help support the urethra. But if your goal is for urge incontinence, so you want one that's quick so that it's going to send a signal to your bladder to calm down the bladder so you can make it to the bathroom. And for prolapse, it's also the strength one. So I don't think there's one that's better than the other, but I think they have different roles. So practicing both of them is good habit.
And we have another question regarding tearing. Do you know if you tear in a first birth, if you are more at risk of tearing in the subsequent birth?
Not necessarily. So I'm assuming you're referring to tearing in the perineal area. So no, I don't think it's necessarily true. The first birth is usually the hardest one. For lack of a better word, the first baby is kind of making the passage for the next baby. So if you tore on the first one and then your second baby is smaller, for example, it doesn't necessarily mean that you're going to tear in the second pregnancy.
Thank you. We had a question from a listener who said her 85-year-old friend is suffering from incontinence. She's not exactly sure which type, but can we help that person even at that age?
Absolutely. So a large proportion of my patient population is in their 80s or 90 years old. And like I said, sometimes even if the person is not clear, we have tests such as the urodynamics that can help clarify exactly what we need to address. And we have a range of conservative therapies that we can try first. And we also do surgeries on 80 and 90 years old under spinal anesthesia, not general anesthesia, and help in this way.
And I know you had this on the slide, but someone's asking for you to reiterate how many Kegels to do on average per day.
So these are, there's going to be variation in recommendation for that. But my routine is to tell people to do 3 sets of each of them, of the duration exercise and 3 sets of the strength exercise. So I tell people that nobody's going to know when you do your Kegels, right? So this is something very private. Nobody needs to know. So 3 times a day you have your breakfast, lunch, and dinner. While you're sitting there, you're eating your cereal. You can do your Kegels, and nobody's going to be aware of what you're doing. So as long as you can link it with an activity that you do 3 times a day, then I think you're going to be okay. So the recommendation that I have to do 3 sets of 15 and 10, there's variation between that, but it's anywhere from 10 to 15 repetitions.
And this is an interesting question from someone who miscarried twins at 16 weeks. She's feeling several kinds of pain in her pelvic area, throbbing, sharp, and dull, that she didn't have before. And then before pregnancy, she worked out all the time, was pretty flexible and strong, and now cannot stretch her legs wide or lift her legs up or squeeze them tight. What would you recommend for this person?
This person would definitely benefit from an evaluation either from a urogynecologist or a pelvic floor therapist, pelvic physical therapist. It sounds like there may be some misalignment or some tenderness at certain point, what we call the trigger points, where the muscle is sore. Again, we work in a collaboration with our pelvic floor therapist. We can help you do certain exercise to strengthen the muscle and realign your pelvis. And sometimes you need what's called a trigger point injection, where we have to put an injection at these points specifically to relax the muscle or to help you with the pain. And so there's different things that we can offer for that as well.
And just 2 more. One is, what are the options, consequences, best treatment options for women who experience prolapse early on and even during their pregnancy?
So this comes less frequently, but during the pregnancy, I would say I've done pessaries during the pregnancy that help people reduce their prolapse. And the second part of the question was if it happens early on before menopause. So there are, again, people who are very comfortable with their anatomy are very good at putting and removing the pessary during certain particular activities. So I think that's a good option. And we try to stay conservative in this situation until they've completed their childbearing, because any surgical intervention the following pregnancy may cause some damage and lead to scar tissue, so that after that their surgery in the future may not work as well. So for somebody who's not done with childbearing, we try to concentrate on conservative therapies such as the pessary, and we work in coordination with the physical therapist to help them. In this situation, I usually recommend to try to avoid surgery until you're done with your childbearing, because we rather have you complete that and do the surgery once and well. However, there are special situations where we have to intervene because there's a serious prolapse. It comes out. Okay.
And then we have a question from our moderator here. Wants to know about perimenopause and how that can affect these issues.
So the most common symptoms that I see in perimenopausal women is it's the beginning of the lowering of the estrogen level. So they get a lot of urinary, what I call irritative voiding symptoms. So urgency, frequency, and those kind of issues. So we work with them as well with dietary modification to avoid things that they've done their whole life and never bothered them, but all of a sudden every time they drink a cup of coffee, they can't get to the bathroom in time. Every time they have a latte with Splenda, but they don't make this association. So we try to elucidate these things with them. We use vaginal estrogen, and we work with pessaries and Kegels to help them prevent any problems in the future. There's things that can have happened in their past, such as pregnancy. We would cover these things to try to see what's the most likely cause of their symptoms. But in perimenopausal, in my experience, it's always, it's not always, it's most likely what we call irritative voiding symptoms that brings that brings them to us. Okay.
And our last question, a curious listener wants to know, why did you choose GYN obstetrics as a field to study?
So I do get this question quite a bit, and I wish I had a better Hollywood story to tell you that I had a great moment that the light bulb went off. But I think the reality is I grew up around women. I'm the third of 4 children. I'm the first boy. I have 2 older sisters. So I spent a lot of my youth with my sisters, and I've always been comfortable with women, and I enjoy taking care of women, and I enjoy helping them improve their quality of life. To me, it can be a challenge because, of course, for some women it's easier to speak to a female doctor, but I view this as a challenge to gain their trust and get them to trust me and develop a good relationship and help them improve their quality of life. So no big story. Is I think I'm a product of being the 3rd child and having 2 older sisters and feeling comfortable with women.
That's great. Thank you so much, Dr. Lefevre. And thank you all for attending, all our listeners. Please visit our website at IsisParenting.com to sign up for our free age and stage-based newsletters from pregnancy to preschool. And make sure to visit our online learning page for many more pregnancy and parenting webinars on a wide range of topics. Watch your email tomorrow for a link to this recording, as well as additional resources provided by Dr. Lefevre and ISIS Parenting. Thank you from all of us here at ISIS Parenting, and good night.